Welcome to Dr. Amanda Clarke, Heart Health and Cardiology. Today we are talking about cholesterol, the full truth that your doctor never had time to explain, and that most Americans are still getting wrong. Let us get into it. Imagine you are sitting in the waiting room after your annual checkup. The nurse hands you a printout with your lab results. There are numbers on that page, rows of them. Total cholesterol, LDL, HDL, triglycerides. Each one has a little flag next to it. Some say normal. One says borderline high, maybe one says high. And the doctor spent approximately 90 seconds explaining what any of it meant before moving on to the next item on the list. You walked out of that office with a piece of paper in your hand and more questions than answers. You might have Googled some of it on the drive home. You might have gotten completely different information from 3 different websites. And somewhere in the back of your mind, the word cholesterol is sitting there like a quiet worry you cannot quite resolve, because nobody ever took the time to explain it to you completely. That is the experience of tens of millions of Americans every single year. And it matters enormously because cholesterol is not a simple subject. It is not simply good or bad, high or low, dangerous or fine. It is a complex set of measurements that tell a story about your cardiovascular health. And when you understand what that story actually says, you are in a completely different position to protect yourself and the people you love from America's #1 killer. Today we are going to cover everything: what cholesterol actually is and where it comes from, what each number on your lab report really means and what it is telling you about your arteries, the biggest myths about cholesterol that are still circulating and confusing Americans right now, what the numbers that actually concern cardiologists look like, and the specific changes in your diet, your lifestyle, and potentially your medical treatment that have the strongest evidence behind them for genuinely improving your cholesterol picture. Stay with us until the end because the section on cholesterol myths is where most people discover that something they have believed for years is simply not true. And that discovery can change how they eat, how they think about their risk, and how they talk to their doctor going forward. Let us start with the most basic question. What actually is cholesterol? And here is where most people are already working from an incomplete picture. Cholesterol is not a poison your body accidentally produces or something that sneaks in entirely through bad food choices. It is a waxy substance that your liver makes on purpose because your body genuinely needs it. Cholesterol is used to build the walls of every cell in your body. It is used to produce certain hormones, including testosterone and estrogen. It is used to make vitamin D when your skin is exposed to sunlight. It is used to produce the digestive substances that help your body break down food. Without cholesterol, you could not survive. The problem is not cholesterol itself. The problem is what happens when certain types of cholesterol are present in the wrong amounts in your blood. And here is the part that genuinely surprises most people when they first understand it clearly. About 75% of the cholesterol in your blood is produced by your liver. Only about 25% comes from the food you eat. Your liver is constantly making cholesterol whether you eat any of it or not. And here is why that matters. When you eat more dietary cholesterol, your liver typically compensates by producing less of its own. The system has a natural balancing mechanism. That does not mean diet has no effect on your cholesterol levels. It absolutely does. But it means the relationship between what you eat and what shows up on your lab report is more complicated than most people realize. More on that in a few minutes when we get to the myths. Now let us talk about what is actually on that lab report and what each number is telling you. The first number you will see is total cholesterol. This is the combined measurement of all the different types of cholesterol in your blood. A total cholesterol below 200 milligrams per deciliter is generally considered desirable for adults. Between 200 and 239 is considered borderline high. 240 or above is classified as high. According to the most recent data available, approximately 86 million American adults have total cholesterol levels above 200, and around 25 million have total cholesterol above 240. These are not small numbers. They represent an enormous portion of the American population living with elevated cardiovascular risk that in many cases is going unmanaged. But here is what most people never find out. Total cholesterol alone is not the most useful number on that report. It is a starting point, not the full picture, because total cholesterol includes both the types of cholesterol that damage your arteries and the type that actually protects them. And knowing the total without knowing the breakdown is a bit like knowing the total number of people on a plane without knowing how many are pilots. The breakdown is what matters. The second number on your report is LDL cholesterol. This stands for low-density lipoprotein. You have heard it called bad cholesterol, and that is a reasonable shorthand for understanding what it does. LDL particles carry cholesterol through your bloodstream, and when there is too much of it circulating, LDL deposits cholesterol into the walls of your arteries. Over time, that buildup becomes what we call plaque. The arteries gradually narrow. Blood flow is restricted. The heart has to work harder to push blood through narrower passages. And if a piece of that plaque breaks loose and a clot forms, the result is a heart attack or a stroke. This process is called atherosclerosis, and LDL cholesterol is one of its primary drivers. For most adults, an LDL below 100 milligrams per deciliter is the goal. For people who already have established heart disease or very high cardiovascular risk, cardiologists often aim for LDL below 70. The third number is HDL cholesterol. This stands for high-density lipoprotein. HDL is called the good cholesterol because it works in the opposite direction from LDL. HDL particles travel through the bloodstream picking up excess cholesterol and carrying it back to the liver where it can be broken down and removed from the body. Think of HDL as the cleanup crew for your arteries. Higher HDL levels are associated with lower cardiovascular risk. Ideally, your HDL should be 60 or above. Below 40 in men and below 50 in women is considered low and represents an independent risk factor for heart disease. About 17% of American adults have HDL levels that fall below the healthy threshold. And yet, when people talk about their cholesterol, HDL is often the number they know least about. The fourth number is triglycerides. These are a different type of fat that circulates in your blood. Your body converts excess calories, particularly from sugar, refined carbohydrates, and alcohol, into triglycerides and stores them in fat cells for energy. When triglyceride levels are consistently high, particularly in combination with high LDL or low HDL, the cardiovascular risk picture becomes significantly more concerning. A normal triglyceride level is below 150 milligrams per deciliter. Levels above 200 are considered high, and for people who eat diets heavy in processed foods, sugary drinks, white bread, and refined grains, elevated triglycerides are extremely common even in people who think their diet is reasonably healthy. Now here is the number that should concern every American. Ask yourself, honestly right now. Do you know your LDL number? Do you know your HDL number? Do you know where your triglycerides sit? If you cannot answer those questions with confidence, you are in the majority of Americans. More than half of the adults who could benefit from cholesterol management are currently not on any treatment for it. That is not because they do not care about their health. It is because the information has not reached them in a way that made them feel the urgency of acting on it. Let me tell you about Michael. He was 48 years old, a sales manager from Illinois, someone who exercised a few times a week and considered himself in reasonable shape. He had not had his cholesterol checked in almost 3 years because nothing felt wrong. When his company introduced a free health screening, he went mostly out of convenience. His results came back with a total cholesterol of 238. His LDL was 152. His HDL was 39. Well below the healthy threshold. And his triglycerides were 220. None of those numbers, taken individually, felt catastrophic. But together, they painted a picture of a cardiovascular system under real and progressive stress. His doctor used the word concerning. Michael had genuinely not known, and he had felt perfectly fine the whole time. That is what makes high cholesterol so particularly dangerous as a health condition. It produces no symptoms, there is no pain, no visible sign, no alarm your body sounds to tell you something is wrong. The damage builds silently over years and decades until it reaches a threshold where something breaks. And when something breaks in the cardiovascular system, the consequences are severe, sudden, and sometimes irreversible. Feeling fine is not the same as being fine. High cholesterol is one of the clearest examples of that truth in all of medicine. Now let us talk about the myths. And this is the section that most people learn the most from, because some of these misconceptions are deeply embedded in the way Americans think and talk about food and health. The first myth is one that shaped decades of American dietary guidelines. The myth is that eating cholesterol raises your blood cholesterol. For a long time, Americans were told to limit egg consumption, to avoid shrimp, to be cautious about any food that contained dietary cholesterol. That advice came from early research that suggested a direct link between dietary cholesterol intake and blood cholesterol levels. But the full body of evidence that accumulated over subsequent decades told a more complicated story. In fact, the official dietary guidelines for Americans actually removed the specific daily limit on dietary cholesterol intake because the evidence did not support a direct one-to-one relationship between eating cholesterol and raising blood cholesterol in most people. When you eat more cholesterol, your liver tends to produce less. The balance shifts. What matters far more for your blood cholesterol levels than dietary cholesterol is the type of fat you eat alongside it, specifically saturated fat. Saturated fat, found in red meat, full-fat dairy, processed foods, and fried foods, has a much stronger and better established relationship with raising LDL cholesterol than dietary cholesterol itself. Recent research has confirmed that eggs, for example, which contain cholesterol but are relatively low in saturated fat, do not raise LDL cholesterol in the way that foods high in saturated fat do, particularly when eaten as part of a diet that is otherwise low in saturated fat. Now here is what the research actually shows about what you should actually be limiting in your diet to protect your cholesterol numbers. Saturated fat is the primary dietary driver of elevated LDL cholesterol for most people. The foods that have the strongest negative effect on your cholesterol profile are those with high saturated fat content. Fatty cuts of red meat, full-fat dairy products like butter and cheese and cream, processed meats like sausage and bacon, fried foods, pastries, and commercially produced snack foods, replacing saturated fats with unsaturated fats. The kind found in olive oil, nuts, avocados, and fatty fish has a meaningful positive effect on LDL and HDL levels and is one of the most evidence-supported dietary interventions in all of cardiovascular medicine. The second myth is that if you feel healthy, you do not need to worry about your cholesterol. We have addressed this already, but it is worth saying again clearly. High cholesterol causes no symptoms. None. The atherosclerotic process that it drives can progress for 10 to 20 years in complete silence before any clinical event occurs. Regular cholesterol screening is the only way to know where you stand. The American Heart Association recommends that adults age 20 and older have their cholesterol checked at least every 4 to 6 years. People with known risk factors or a family history of heart disease should be screened more frequently. When did you last have yours checked? The third myth is that only older people need to worry about cholesterol. This is dangerously false, and it is increasingly contradicted by the data we are seeing in American health statistics. Cholesterol levels and arterial plaque accumulation can begin in early adulthood. In fact, autopsy studies of young Americans who died from accidents and other non-cardiac causes have found early signs of atherosclerosis in people in their 20s and 30s who had no diagnosed heart disease. The habits that protect or damage your arteries compound over time. Starting to pay attention to your cholesterol in your 30s and 40s gives you a much longer runway to intervene before damage accumulates to dangerous levels. Starting to pay attention at 60 is still enormously valuable, but you are working with a shorter timeline. The fourth myth is that statins, the class of medication most commonly prescribed to lower LDL cholesterol, are dangerous and to be avoided if at all possible. Statins are among the most extensively studied medications in the history of modern medicine. The evidence for their effectiveness in reducing heart attack and stroke risk in people with elevated cardiovascular risk is very strong. Like all medications, they carry potential side effects. The most commonly discussed is muscle pain or discomfort, which occurs in somewhere between 2 and 10% of patients. And importantly, studies have found that roughly 90% of patients who experienced muscle symptoms on one statin were able to tolerate a different statin with continued use. If you have been told you need a statin, and you have concerns about side effects, please have that conversation with your doctor directly, rather than simply declining the medication. The conversation about which statin at what dose with what monitoring deserves to happen. What should not happen is a decision to avoid treatment entirely based on fear of side effects that may be manageable or may not occur at all. Let me tell you about Susan. She was 55 years old, a teacher from Georgia, who had been told 3 years earlier that her LDL was high enough to consider a statin. She had read things online that scared her. She had seen posts suggesting that statins were unnecessary, that they caused more harm than good, that the cholesterol-heart disease connection was exaggerated. She decided to try to manage it through diet and exercise alone, without medication. Her diet improved. She exercised more consistently, and when she came back for a follow-up, 2 years later, her LDL had come down somewhat, but not to the level her doctor was aiming for given her overall risk profile, which included a family history of heart disease on her father's side. Her doctor sat with her and went through the actual trial data. They talked about her specific concerns. They found a statin at a low dose that she was comfortable trying. At her next follow-up, her LDL was at goal for the first time in years. Susan told her doctor she wished she had had this conversation 3 years earlier. Now here is something your doctor may not have had time to explain about the lifestyle changes that genuinely move the needle on your cholesterol. Diet and exercise are genuinely powerful. For some people, they are sufficient. For others, they are not enough on their own and medication is needed. But in all cases, they matter. Reducing saturated fat intake is the most evidence-supported dietary intervention for lowering LDL. Increasing soluble fiber, found in oats, beans, lentils, fruits, and vegetables, helps the body remove cholesterol before it is absorbed into the bloodstream. Regular aerobic exercise, even moderate exercise like brisk walking for 30 minutes most days of the week, raises HDL and lowers triglycerides. Weight loss in people who are significantly overweight improves every component of the cholesterol profile. And stopping smoking, for those who smoke, has a meaningful positive effect on HDL specifically. Think about how many of those interventions apply to your own life right now. If you eat a diet high in processed and fried foods, if you are not getting regular aerobic exercise, if you are carrying significant extra weight, if you smoke, then the improvements available to you through lifestyle change are real and they are measurable. They show up on your next lab report. They are visible in the numbers. And for many people, the motivation to make those changes becomes much stronger once they actually understand what those numbers mean and why they matter. So what should you do with everything you have learned today? The first thing is to know your numbers. If you have not had your cholesterol checked in the past year, and you are over 40, or if you have any risk factors including family history, diabetes, high blood pressure, or excess weight, making that appointment is the most important thing you can do for your heart health today. Not next month. This week. The second is to understand what your numbers actually mean. Ask your doctor specifically about your LDL, your HDL, and your triglycerides, not just your total cholesterol. Ask where your numbers sit relative to the goals for someone with your specific risk profile. Those goals are not the same for everyone. A person with no cardiovascular risk factors has a different LDL target than someone who has already had a heart attack. Understanding your specific target gives you something concrete to work toward. And the third is to have honest conversations about treatment. If your doctor recommends a statin or another cholesterol-lowering medication, engage with that conversation fully. Ask about the evidence, ask about the risks, ask about the alternatives, and ask what happens to your long-term cardiovascular risk if treatment is deferred. You deserve complete information. And your heart deserves decisions made with complete information, rather than fear or confusion. Cholesterol is not the enemy. Unmanaged, misunderstood cholesterol in the context of a high-risk cardiovascular profile is the threat. And the difference between those two things comes down entirely to knowledge, conversation, and action. If this video gave you a clearer and more complete understanding of what cholesterol actually is, what your numbers really mean, what the science actually says, and what you can do starting today to take better care of your heart, subscribe to Dr. Amanda Clarke and turn on notifications so you never miss a video that could genuinely protect your health. And drop a comment below answering this question. Honestly, do you know your LDL and HDL numbers right now? And has your doctor ever taken the time to explain what they mean for your specific situation?